So, good morning, guys. As you guys know that I was feeling a bit unwell, so I have this feeling that the message was not as clear as I wanted to be, just because of so many things happening on that day, especially my asthma playing hardball with me. So, what I thought that I should do is we have a follow-up videos, so that I can summarize the important concept for you. And it is really important for me that you understand the practicalities of treating asthma and COPD, because it has quite a high prevalence in our society. So it's really important that you guys understand how these diseases being treated in practice, and what are the key medicines and how you manage them. So what we are going to do to make things short and easy to follow is we are going to have follow-up videos, which are 3 videos. Altogether, we only will talk about in 3 videos. Video 1, I'm going to cover the brief overview of asthma and COPD, as well as what are the common medicines we used in asthma and COPD. Video 2, we are going to focus on what happened on every day in these patients' life. So chronic treatment of asthma as well as COPD. While video 3, we are only going to look at the emergency treatment and how we manage asthma and COPD when somebody is in acute respiratory distress or having an acute attack of asthma or COPD. So as you guys know, obstructive respiratory disease has one common features, that they have obstruction in airways, so patients are unable to inhale or breathe properly. The main diagnostic or the main pathological feature in these diseases is that they are unable to empty their airways adequately, so that's they are unable to fill it with air. In asthma, the obstruction is mainly reversible, while in COPD the obstruction is mainly irreversible, although in acute asthma, when it's been poorly controlled for a long period of time, can lead to some permanent damage in lung, while in COPD as well you have bad days and good days, and those fluctuations exist. But pathologically, they are irreversible. COPD presentation, while asthma presentation are quite reversible. This is just an illustrative example, just to highlight the fact that in asthmatic patients, the airways are usually compromised to start with, so they are more sensitive to certain insult and certain acute mediators of bronchoconstrictions. In chronic bronchitis, is mainly can be the loss in elasticity of airways, as well as the thickness of the bronchioles as a normal uh, pathological process in COPD patients. At the end is obstruction, and that's what we are going to treat. Now, in terms of diagnosis, you can see in asthma you will have some sort of childhood onset history, and in COPD patients you are going to have more of uh, an adult onset in late 30s, early 40s, depending upon some sort of occupational hazard, either through smoking, socially smoking history, or working in mines, or working with coal, and working in situations which can lead to these problems. Passive smoking is also important when you are looking at COPD and taking the history. Asthma presentation can be tricky, especially in kids, when there is only nocturnal cough that is present in many patients, especially kids are unable to clear up their airways because of constriction, and they just cough as a reflex. So sometimes it's difficult, but when you are going to look at asthma patient has to have some sort of history of acute shortness of breath from their childhood. Cystic fibrosis, we are talking about it. Spirometry is important because we use spirometry to grade different level of diseases with COPD and asthma. Less than 80% of predictive value of forced expiratory volume over 1 second, which is FEV1, tells us that there is some sort of obstruction. And as you'll see in the treatment, maintenance treatment, as well as acute treatment, we use these values to classify the severity of underlying disease. So about treatment and medicines, as we discussed in lecture, most of the treatments and medicines in COPD and asthma are delivered via inhalation because that's where the problem is. We hardly use oral medicine these days. The only oral medicine we are going to cover is Montelukast, which is a type of indirect bronchodilator, and then we are going to cover the treatment. So, as we discussed before, to make it simple, to make it very relevant to the clinical effect of these medicines, all of these medicines open up airways. Some of them open up airways indirectly, some of them open airways directly. Excuse me. So direct bronchodilators are the one that are directly acting on our smooth muscles of lung to open up our airways. Indirect bronchodilators are doing something in our body which leads to generally less swelling and less inflammation, and because of that our airways are being open. Now there are other treatments. There are treatments that are reserved for less than 5 or 10% of difficult to treat asthma. We are not going to cover that because I don't think that you need to know those complex treatment at this stage because you won't be practicing an advanced respiratory discipline right after you finish your graduation, and there will be a time if you are going into the respiratory specialization, then you'll probably have underlying training, you have more education in that field, so that's why I think we should restrict our discussion to the common medicines. So just quickly, when it comes to direct bronchodilators, it's easy to remember they are shock acting bronchodilators. So if you are suddenly having an acute attack of asthma, that's where you need something to work quickly. So you can't just wait for longer acting drugs to give you the relief because they are going to take time. While short acting drug, bronchodilator will open up your airways immediately. So that's why bronchodilators are of two major types, short acting and long acting. Within short acting, there are two types which are beta adrenergic, so which acts on our beta receptors in lungs, and the other one is anticholinergic or antimuscarinic that works on our muscarinic receptors and block them, and because of that we have bronchodilation. So our beta 2 receptors, when stimulated in our lungs, they open up our airways. Our muscarinic receptor, when they get activated, they close our airways. The easiest example is methylcholine, the cholinergic receptors. Whenever they are stimulated, they restrict your airways. So if you block similar receptors, you're going to open up your airways. So within beta 2 adrenergic, we have shorter acting one, which are commonly known as salbutamol or Ventolin, and terbutaline or Bricanil. While in longer acting one, we have many of them, such as salmeterol, indecterol, viranterol, formoterol. Most of them, almost every one of them, have this erol at the end. So these means they are the longer acting beta adrenergic agonist, and then we have muscarinic agonist. The only shorter one available is ipratropium, or also known as Atrovent. While longer acting, we are increasingly getting more, but for a long time we only have tiotropium, which is Spiriva. At this stage, I think it will benefit for you to just go back and look at the inhaler chart. So this was the inhaler chart that that I've provided to you with the material. So as you can see, these are the shorter acting beta adrenergic agonist inhalers. So salbutamol comes in various form, various devices, and then Bricanil is only comes in one particular device. We are going to briefly cover about what these devices are and how they are differ, but let's only talk about the bronchodilator at this stage. So these are the SABAs. So these are the shorter acting reliever, quick reliever. So if you are under acute attack, you want these blue ones, the top one. Now these are the longer acting beta adrenergic agonist. So they are beta adrenergic agonists, but they are longer acting. So we have formoterol, various form of formoterol, salmeterol, indecterol. We have again another brand of formoterol, and then we have this olodaterol. So as you can see, erol, 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 erol. So yeah, so all of them have erols in it. So these are the LABAs. But remember, there was the third one, which was the shorter acting and the longer acting muscarinic antagonist. Sorry. So these are the ones that act on muscarinic receptors, and as you can see, the longer lasting in our market was Spiriva. That was the first one. It still is there. And then we have aclidinium, we have omeclidinium, we have glycopyrenium, tiotropium, a mist form, and this is one which is SAMA. So as you can see, the chart says SAMA is only one, which is atrovent. So this is the shorter acting one. It's going to take a minute or two to just show its maximum effect, compared to all of these ones, which are going to take at least a good hour to show their effect, but they are going to last longer. So as you know, direct bronchodilators, so we have muscarinic antagonists, we have longer acting beta agonist, we have shorter acting muscarinic agonist, and we have shorter acting beta agonist. So I suppose now it's a bit more clear that what these are. Now the other ones, which are the indirect bronchodilators, so we have three of them. So indirect bronchodilator, we have inhaled corticosteroid, and we have cromolins, and we have leukotriene receptor antagonist. Now indirect bronchodilator, as you remember that in asthma you have an underlying inflammation that keep building up if you don't suppress it, and we have short-term constriction. So if you suddenly run quickly, if you are exposed to cold, you have this sudden shortness of breath. At that time you are going to use a quick reliever so that you can get rid of that sudden shortness of breath. But in every asthma patient, you are going to have this underlying inflammation. So when you are treating somebody on a long-term basis, you use these medicines. So you have the steroids that can take control of the inflammation. You have leukotriene receptor antagonists that reduce the inflammation by reducing the leukotrienes related inflammation. And then you have cromolyn, which stabilize your mast cell release or histamine release in the body. So it's really important that you know that there are these indirect bronchodilators that are using all their mechanism of action to reduce the inflammation. Now, as we discussed before, we are not going to go into all the complicated ones. So inhaled corticosteroid, again, there are many of them, and there are so many types, there are so many strengths. But what you need to understand, excuse me, that almost all of the inhaled corticosteroid except one is twice daily dosing. So you use them in the morning and in evening. They have different strengths. So they have low dose, moderate dose, and high dose. And you usually use low dose for initial disease, moderate dose for a more complicated and persistent disease. And then if you are using high dose, that's an indication that you need to have a more closer follow-up and identify what's being a problem. And now I'm not going to cover MDI versus DPI just right now before I finish all of the medicines, and then we are going to discuss the device a little bit. So let's look at what are some of the low dose, moderate dose, and English. So if you look at the steroids, the most common one then you are going to see in practice is beclomethasone, budesonide, and fluticasone, and all of them will have low dose, medium dose, high dose. You don't need to remember these low, medium, high dose, but it's really make sense when we look at these classification and the treatment of asthma, according to the guideline, which we are going to cover in our second video. Leukotriene antagonist, there is only one, which is montelukast being available. It's very straightforward drug. We have low dose, again moderate dose, and high dose. So high dose is the adult dose, moderate dose is for kids between 6 and 14. Excuse me. And then we have low dose, which is under 6 years of age of children, which is 4 milligram. These are not the nicest drug available compared to the inhaled medicines. So we usually use them when we are not getting good relief from the first line treatment, which is our inhaled corticosteroid. Cromolins, very small part of treatment. They are not steroidal in nature, but they can be used for chronic asthma. So that's why sometimes they are used if patients are unable to tolerate the first line treatment. They have their own logistical issue. They are very sticky material, so it's very difficult to clean it. It's very difficult to manage things. But in very small population of our patients where they cannot choose other things, then we use cromolyn sodium. And the way they work is they prevent histamine release in our body whenever we have an acute asthma response. Now, inhaled corticosteroid are so many. So let's go back to the inhaler chart. So there are a lot of them, but also they have a lot of combination. So let's see. So these are the inhaled corticosteroid. Excuse me. And these are some of the combination. Like they are not all the combination here, but they are some of the combination. And you will see that inhaled corticosteroid, which are say beclomethasone, and then budesonide, fluticasone. So if you see, they are the three main types, and there are so many different strength of it. But they also come in combination with ICS and LABA. And then again, the LABA and LAMA, which we discussed earlier, direct bronchodilators. So the two direct bronchodilators are also available as a combination. And now we are also looking at where there's an increasing number of ICS and LABA combination starting from here. So you can see that we have beclomethasone with formoterol, and we have budesonide with formoterol, we have fluticasone with formoterol, and we have vilanterol with fluticasone. So there's so many of them. There are a lot of them. So each time you have these inhalers, you need to ask yourself that what a particular device is, read about it before advising somebody on using it, and understand how they work. I'm going to discuss the side effects of medicine in context of the treatment. So you can see that how medicines are relevant when you use them in practice, and that will also make you appreciate that why we have certain medicine being prescribed at an early versus at later stage. So now we are going to move to over the second video, where we are going to look at the treatment of chronic asthma and treatment of chronic COPD.